Good afternoon, everyone, and welcome to the Campus Lisa webinar series. My name is Angie Liu. I'm one of the project managers for Information Technology Services, and I will be your show host for the hour. Before I introduce our session for the day, I have a few housekeeping items I should go over with you. The session is being recorded and will be captioned and available to view on campuslisa.ucsd.edu. The presentation will be about an hour long with some time at the end for Q&A. Please use the Q&A window at the bottom of your screen to ask any questions as chat will be disabled. Our session today is automating the compliance of health research with Virtual Research Desktop. Dr. Michael Hogarth, the UC San Diego Health Clinical Research Information Officer and Professor of the Division of Biomedical Informatics, is here to kick off the session. Please join me in giving a warm virtual welcome to Dr. Hogarth.
Thank you, Angie, and everyone. Welcome, and thank you also to those who put on the Lisa webinars for the opportunity to present to you all today. Today we're going to be talking about something we've done over the last couple of years, which we call the Virtual Research Desktop. My co-panelists today are Nguyen Trieu, my Associate Director of the Biomedical Informatics Group at the Altman Clinical Translational Research Institute, Andrew Greaves, our Enterprise Cloud Architect at UC San Diego Health, and then Bhattacharya, CEO and founder of Xpertech. To get this sort of started, I think what we want to kind of get to here is the rationale behind the Virtual Research Desktop. If we could move the slides forward and maybe put it in presentation mode, that would maybe make that better for folks today. Give us a minute here to try to get this going. There we go. We'll make some changes here. Basically, I'll get the slides queued up. Why did we do the Virtual Research Desktop and why is it important? And really, there were a series of things that really happened to us over when I got here 3 years ago that really made it compelling to do something like this. The first was inappropriate removal of UC research data assets. These were not protected health information, but was nevertheless a data asset of UCSDs that a investigator who was recruited to USC had put into an Amazon environment that they had paid for. This was their own personal account. There was no opportunity, or at least they didn't avail themselves of the opportunity to have a UCSD account at the time. And they uploaded all their data from their project. And then when he was recruited to USC, he downloaded it to USC. That resulted in a lengthy court battle, and everybody's probably seen this, that USC apologized and paid UCSD a settlement. Another was not infrequently, I was asked to work with the team to move data that was protected health information to an external entity by investigators who then said the IRB had approved it. And beyond IRB approval, even though that's necessary, it's not sufficient, one needs a data use agreement. What I found was folks were being given data sets and then they were providing them to external entities without really a whole lot of oversight. The other is that it's a common risk for data breaches in healthcare, certainly to be due to the loss of laptops and mobile devices that have protected health information on them. A very well-known one was the Sutter Health breach, which was actually a laptop that was stolen from an office at Sutter Hospital. It happened to be unencrypted. It had all 4.2 million Sutter General patients on it. That resulted in a class action lawsuit that I think they're still paying for, and the cost of which is ranging somewhere in the billions. And then last but not least, I'm sure a lot of people are aware of what happened last month And again, this was not protected health information, but this was a collection of data from 50 investigators who had collated their resources together on a platform that was not 100% secure, or at least was subject to an attack, a successful one, by ransomers who then extracted upwards of $1 million from UCSF for the key. So all of these things together have really led to a need to actually have a place where we can put data assets and things of value, including regulatorily protected data, in an environment that deals with all of these use cases. So the next step here is we're going to talk a little bit about compliance, because there are some issues related to health information in particular, and I know not everybody in the audience is an expert in this area, so we wanted to provide sort of a background, which then adds to the rationale for this project.
Thanks,
so
Mike.
Go ahead, Andrew.
I'm Andrew Greaves. I just wanted to kick this off, but I thought it was important for you, Mike, to give a little background on your first week at UCSD. That was the serendipity that kind of brought us together to kind of develop this UCSD secure cloud.
Yeah, certainly. On I think my first week, my 5th day actually at UCSD, I saw a colleague from my division come to the ACTRI and then with a flash drive and then walk away. And when I asked what that was about, it was a approved data extraction, IRB approved, of 10 million clinical notes with full PHI. And the tradition at that point had been to put the data in a SharePoint environment from which individuals would download it or put it on their device. This was too big for that, so he walked up with a flash drive and walked away with 10 million clinical notes in an encrypted flash drive, but nevertheless, it wasn't institutionally provided. So that kind of made it very clear that we needed to move away from that kind of workflow. That's when I actually met Andrew, and we started working together to kind of make this virtual environment a reality.
So in parallel with Mike's story, around that same time, we were brought together to do some risk assessment. And one of the things that was presented to us that, hey, by the way, you have about 800 UC San Diego Health associated AWS accounts. Now we have zero visibility, no security controls, no monitoring from a centralized standpoint in those accounts. We didn't know what type of data or workloads or potential risk that were associated with those accounts. So that being a giant red flag, one of the things that kind of curtailed around that was that we also didn't have an environment to put them into an AWS. Now, it's not that we didn't have HIPAA compliant areas that people could do research, but one of the advantages to AWS is all the service availability, the scalability. So we met with AWS in late 2017, and we engaged their professional services along with Xpertech to help build out what we are now calling the UCSD Health Secured Research Cloud. We partnered right off the bat with our internal security team in information services, as well as large research departments like ACTRI, Department of Biomedical Informatics, and other health research groups that were AWS familiar. So I want to give you just a quick high-level view of some of the compliant or some of the regulatory rules / laws that we are responsible for providing in terms of that secure environment. So one is a federal act that was passed by Congress in 1996. I'm sure many of you have heard of HIPAA. It stands for Health Insurance Portability and Accountability Act, and it defines ePHI. With 18 identifiable elements, things like name, social security number, email address, and then the 18th, which is probably the most challenging to deal with, any unique identifying number, characteristic, or code, except, when you're dealing with that, what is that definition? So there's a lot of gray area there. But that being said, it also, HIPAA defines the concept of the covered entity, and that means health plans, healthcare clearinghouses, as well as healthcare providers that transmit health information. And so I'm going to cover that topic a little bit when we talk about AWS and the extension of this concept of the covered entity. But it's important to note that HIPAA is really just a policy. It's not specific security guidelines. As a matter of fact, they only mention 2 specific technical controls. One, no generic logins, so like doctor with password doctor, shared logins is not acceptapable, and they mention encryption, but they don't define specifically what types of encryption protocols you're required to use. Rather, they just left it generically open, which is a good thing, because we might be stuck with 16-bit encryption, since this was way back in 1996. And then in California, we have another act that actually has a lot more teeth to it for personal liability in terms of those operators in these EPHI environments. So it provides additional protections around medical information, and this is again in California only, though there are other states who have produced such statutes that are similar. In particular, like I said, personal and administrative fines and penalties that can include jail time. So if somebody nefariously does something, goes in unauthorized and discloses patient information on, maliciously or otherwise, like I said, it can include jail time. So that's the teeth here with the lion picture at the bottom. Really, this provides a little bit more teeth than just the general guidelines of HIPAA and penalties. So 4 technical safeguards or categories for safeguards for ePHI, and this is true of data sets outside of just PHI, but access controls. We need to know who is in doing what within the environment. Those audit controls that are number 2 really talk about the activity inside the information system. Integrity controls, so making sure that records aren't being improperly altered or destroyed. And transmission security, meaning, guarding against unauthorized access. So, a breach or nefarious activity going on inside the electronic health record or systems. So what we chose to map to are compliance frameworks. One was from the National Institute of Standard and Technology, or NIST, and it's a specific framework called NIST 853, which maps to FISMA moderate. Now, FISMA is the Federal Information Security Management Act, and it sets out some very specific guidelines as well in terms of security controls. So this corpus of NIST 853 technical controls also includes organizational controls. So it's not just the technical controls you put in place, but the organizational controls for how people get onboarded or offboarded into systems, et cetera. And then complementary to that, we also are using the Center for Internet Security's level 1 security guidelines. So this is a complementary framework that really allows us to map out vulnerabilities and prevent those vulnerabilities by completely eliminating them. So when we're doing hardening of operating systems or databases, we have very specific guidelines to map those out. So then I mentioned the extension of that covered entity, and this is something called a business associates agreement. Now, many of you may or may not be familiar with it, but what that does is with our vendor and contractor partners, they sign a BAA that basically extends those liabilities if they were to do something inappropriate or nefarious, be it on purpose or otherwise. They are part of that covered entity, meaning those liabilities extend to them. So it's important to note with AWS, and this is true of most cloud providers, there's a shared responsibility model because we're not running the underlying data centers and infrastructure per se. AWS has something called the shared responsibility model. So they are these yellow pieces down on the bottom, the general compute, storage, database, networking, and infrastructure, as well as networking to those and physical security controls around their data centers. We're responsible for everything that happens in the applications and the operating system above on what we install on those, say, EC2 instances. So it's important to note that most cloud providers offer what they call HIPAA eligible services. This does not mean that these services are HIPAA compliant. HIPAA compliance is mapping out to all those security controls, making sure your CISO or your Chief Information Security Officer has visibility into that environment and can do remediations and things like that. The HIPAA eligible service is just a service that can be mapped to HIPAA compliance. And there are services that we are using inside this HIPAA compliant environment that are non-HIPAA eligible services, meaning like identity access management. Well, I'm not going to be storing patient information in there, so they never actually certify that as a HIPAA eligible service. User controls are in there, and we're mapping out, rules and roles within there, but no patient data is being stored there. So with that as a background, when we engaged Xpertech and Bhattacharya, we've asked him to kind of review the architecture that we put in place given all of this background on the compliance and policies, procedures, and technical controls.
Thanks, Andrew. So in the next few slides cover the complete, HIPAA compliant environment. And, to be a fully HIPAA compliant system, we used a combination of HIPAA eligible services from AWS that, Andrew was just referring to, along with all the controls that are required from the customer side. And this slide gives you an overall idea of the defense in depth multi-layered security approach that we used, for the different, sections or parts that are associated with it. So an important concept to understand is the concept of a HIPAA boundary, right? Think of it as the fencing around your property that you want to protect. So in this case, the HIPAA boundary consists of all the accounts that come under the UCSD Health HIPAA organization and the network boundaries that are created using what we are using here is a Palo Alto firewall. So all ingress and egress into this HIPAA environment has to go through those Palo Alto virtual networks and the on-prem Palo Alto network, which goes through the UCSD Health standard networking policies and ingress and egress policies that are associated with it. The other uses that we use the Palo Altos for is a concept of transit gateway that is mentioned here. It allows us to plug in different accounts very easily into a network without creating a mesh network type of an issue. Other very central issues of HIPAA requirements is centralized logging, which we capture in what's called a management account. It is isolated and nobody has access to it other than security personnel. And we capture all sorts of logs from network logs to config logs and systems and database logs that are captured in that central location. Also, we do follow the rules about VPC isolation. This slide shows you how the boundary controls are maintained. Again, an important issue to note here is the concept of a bastion host. So any privileged access, whether it's an administrator or a developer access, has to go through what's called an endpoint, bastion access. So if you follow the lines here, if first of all, the person has to be within the UCSD San Diego Health network, either through VPN or directly physically. But then it goes through the Palo Alto firewalls and then goes up to what's called a bastion host that is managed in the management account, by IS. And from there, it can jump over to any of the resources in the individual accounts that they can have developer or administrator access to, right? And any application users has to go in what's called a transit VPC through an elastic load balancer, but still hits the Palo Alto and then has access only to the application tier of the individual accounts. And this slide, again, quickly shows how isolation is maintained. So every researcher or group has got its own account and then also their own bastions, which are segregated by both security groups and subnets. So as you can see, again, if you follow the line, the top one is an administrator access, and they have access to all the accounts to provide administrative roles, the red lines. But individual researcher only have, if you follow this green line, will have access to their own accounts or things that they're approved for. That's the way that isolation is achieved. Now, this one specifically gets into the VRDs, and what we're using is the AWS WorkSpaces. So on this left side, you can see these are all the workspaces that we have, and this is in one of those managed accounts that is in our HIPAA environment. Now, these workspaces can be grouped for different research groups and for the level of access that they need and the access to resources that they need. Right? Now, the workspaces are connected to the UCSD AD, campus AD. And again, as Andrew had mentioned, the AD connectors are not necessarily HIPAA eligible, but what we do is we route them through the tunnels that are created by the Palo Altos directly into the DC that sits on the UCSD campus side, right? So that's the connectivity we have for joining these workspaces to the AD. And then they're allocated, or provided the privileges based on their approval of certain resources in different accounts using a combination of security groups that are applied specifically to those workspaces. And then we do also use Duo as a MFA for this. And with that, I'm going to pass this on to Nguyen and Mike for the next section.
All right. Good afternoon, everybody. Hope everybody's doing well, and thanks for attending our session today. I'm going to be talking a little bit about the data extraction concierge services at ACTRI within UC San Diego Health, and how we operationalize this service within our department. So as professionals and as just a patient, we can understand the importance of protecting the privacy and security of our health information. And so our information is stored within the clinical data warehouse for research. And typically a researcher who has a proposal for any type of research will then submit proposals to the HRPP department. HRPP is the department that handles human research protections and programming. And so they will review and approve that study. And typically this study will involve extraction of various health data elements from our data warehouse. And they will then work with the PI, and our DECS analyst will extract that information into the VRD for secure storage and analysis. And once it's in the VRD, it'll give the researchers and their collaborators a lot of functionality and affordances with analysis tools such as R, SPSS, and various other tools for analysis as well. And the key here is really that prior to starting the VRD environment, a lot of the data extractions were essentially handed directly to the PIs, as described by my colleagues earlier. And we're really having this research development environment here so that we don't have situations where there are nomadic extractions of data. We really have a clear accounting of any type of disclosure of any type of PHI from a compliance perspective. And it also gives us really that full chain of custody in terms of who, what, when, where, and why, what researcher for what reasons. And it really ties things together nicely from storage and analysis of that data. And as mentioned as well, this process has essentially been approved by the CISO at Health for any type of computation and storage. So next slide, please. So I'm going to take you through here what the experience of the PI looks like. So essentially, anybody who has an account within the VRD will be given a secure code whereby they install the client, and they also have to know their 80 login credentials, as well as be registered for the health dual two-factor authentication. Upon a successful login, then their compute resource will spin up. Typically for any type of resource that's been idle for more than 2 hours and has no type of activity, and it will go dormant or essentially stay on pause until another successful login. This saves on really a lot of the economic costs involved with running the service. And then also, there's just no need for it to be running without any type of processes that are active. Once they log in, essentially, they'll get a very familiar Windows experience that similar to, kind of like the remote desktop experience with all the tools that they need from there. Any type of access outside the VRD is going to be basically restricted based on the architecture that was described. All the tooling and everything else will be stored here. And the next screen here is the secure drop directory. This is where that data extraction of the PHI will land. So the PHI and all of their team collaborators will have a mapped drive that's specific to the study so that they can leverage these data sets against the tools for analysis. And the last screen there is essentially if you open up any type of the tools there, you can basically access that data set within that confined and protected environment. Next slide, please. Okay, here is actually a little bit deeper dive into what that directory looks like. This screenshot is actually a very specific study. This is the VOLI study. And it's all of the various data sets that the DECS analysts have worked with the PI. And actually this study is actually managed by PI Dr. Hogarth here, who's on the panel. And I'll let him talk a little bit about his experience from the eyes of the PI and his team in accessing the data within VRD.
Thanks, Nguyen. If you go back one, actually, I just wanted to highlight, this is one of my projects that I collaborate with computer science collaborators from Qualcomm and creating a dialoguing system. And we needed data to make the system smart and being able to interact with elderly patients has to understand their chart, basically. And so we have a large array of PHI that we had to use here. And that's what you see there. Those are the files that have been extracted, and that's actually my VRD. The next one we'll show you here as a screen capture of using RStudio. I haven't opened any data sets. It's just showing that RStudio is available in the VRD. And because of that, there's R, so the R console is certainly available as well. And I think the next one is another one of the tools we have there. This one is a database tool that we have gotten very favorable licensing for from JetBrains. This is DataGrip, which is a multi-database capable SQL client. And in this case, it's accessing the data set known as CORDS, which is the UC-wide data warehouse distribution of the COVID data set, which started happening about 2 months ago. Again, it has to live in this kind of environment. That's one of the stipulations in being provided that. So people have to they only have access through this environment. The other is that it's a limited data set. So 16 out of the 18 identifiers have been removed. So names are not in there, email addresses, phone numbers, none of that is in there. But yet it is HIPAA regulated, so it has to go, we have it in this environment. I did also want to highlight that when we first started this, we actually started it with an on-prem VMware version of a virtual desktop. And we transitioned to the AWS version simply because it's just much easier for us to manage and more scalable. And we have sort of 2 levels. One is the basic level, which is a 2-core, 4 GB kind of footprint. And the other one is an 8-core, 32 GB footprint. So people can do pretty much everything they normally do on a laptop. And that's the whole point, is to make it look like that. And we're looking at maybe a slightly different view using AWS AppStream, which is kind of like a Citrix approach to this, which is cheaper. But it was important just from a socio-technical perspective to convince many of my colleagues that this really was a laptop in the cloud and just the same as their laptop on their lap. But a lot better because we can make it scale to a level that they just couldn't purchase. And they don't have to worry about the security. And then we can add any tool that they want here. And again, I want to underscore that the browser is there. You cannot connect to Google, Yahoo, nothing from within the VRD, but you can connect to systems internally that are running locally. And we have RedCap and other systems like that, including Tableau. So I'm going to hand it back to Nguyen, who can sort of go over sort of the basics of how data makes it to the VRD.
Thank you, Dr. Hogarth. So I wanted just to describe a few of the segmentation that's happening here with respect to the VRD. The VRD itself is essentially a Windows 10 virtual machine that's running within the AWS infrastructure. And where we get a lot of the economies of scale is really through their management of the overall infrastructure. And as described earlier from the shared responsibility model, we're really managing that application layer, the security, and also just the access and control within that environment. To the far right there is the VPC where the domain controllers live. That is actually managed by centralized ITS folks. And we leverage that environment for all of our identity and access management. And then as we move over to the left there's going to be essentially the IS core management services that we connect with within the ACTRI VPC. And to the left of that as well is essentially our DBMI resources. From there's actually MySQL resources and also various Docker environments that the VRD environment may connect to. We also have connections with S3 buckets and various other data sources, depending on the various needs. And then up on the top there is that connection back to our health system research cloud that's on-premise in terms of that integration. So everything there is interconnected by the Palo Altos, which provides all of the internet protection systems in terms of firewalling, various application access management, and encryption that includes, within our compliance. So everything is essentially very well workflowed so that we can work, interdependently between these various environments and give the PIs that full experience of the various tools that they need, and not have to really worry about the compliance, because it's essentially compliance in a box for us, because all of the automation is happening through AWS.
So I wanted to go through some of the use cases, a couple of use cases. One is the VOLI project, which we mentioned earlier. And again, it requires a fair amount of protected health information, ranging from all clinical notes of patients for the last 3 years, anybody over 65, all the lab test data, their demographics, and any communication they've had with their doctors using the personal health record component of the electronic healthcare record system, which is called MyChart, is this messaging system. And we have all the messages between doctor and patient so that we can understand what patients, what terminology patients are using when they're talking to the doctor, and we want to emulate that in the dialoguing system. So there was a fair amount of PHI there, and we manage it all inside this environment. The next one is the COVID data. There's actually two sets of COVID data. There's UCSD specific COVID registry data, and then there's the UC-wide data warehouse COVID release, which I mentioned earlier, which is, these are actually refreshed weekly. And so the latest one from UC-wide, to give you an idea, has 200,000 patients worth, anybody who's been tested, as well as a collection of about 300 million data elements on those individuals. And again, it's a limited data set, so it doesn't have names. It's basically pseudo identifiers for everybody. Dates of birth are not in there, just years of birth. So this has all been approved by the HRPP at UCSF, and everybody's agreed that this is okay, but it has to be in this kind of confined environment to be used by researchers. To date, we have about 40 or so that have been that have asked for access to the data sets, and we'll describe kind of how we're provisioning that. And as you can imagine, 200,000 worth, 300 million data elements is perhaps not that easy for people to manage, even on a big desktop or laptop in the cloud. So one of the things, once we establish a secure perimeter environment and people are coming in there and they're comfortable with that, the other thing we really need to do is simplify access and perhaps create more automation around that. So that's what we started doing with this tool that we've installed inside of this cloistered environment. And the tool is from a company called TagBio. We call it the Translational Research Portal. And it's really there to provide a high-level analysis, and then the ability to slice and dice cohorts from within the larger data set, and then not have all the data come down, but just what they're interested in. And that's all done inside this environment. The system is running inside. It's web accessible only to the VRDs inside. And on top of that, the system itself has authentication and it has role-based provisioning for access to data sets. And so this is sort of making it so that people don't actually have to know Python or program SQL, because most of my investigator colleagues don't have that skill set. It's expensive to actually pay for it, and we just it's not a very scalable solution if everybody had to do that. We do offer all that, but this is our next step in providing a more simplified view. I wanted to kind of, this is highlighting some of the data sets. There are also other open data sets that have been added to the system. These are not reaching out anywhere. These are actually in the local installation. So I guess we call it something like on cloud prem, or in private cloud on premise, as opposed to physically on premise. But it's basically an instance of the software locally. And that's how we're providing COVID data. And in the future, we are looking to work with our compliance office to see if the same model can be applied to other data sets and other registries like diabetes, hypertension, et cetera. So we can accelerate access to that data in this protected environment in a more simplified fashion. I think the next slide shows a little bit more detail about what the system can do. If you can forward the, so this is just an example showing or a graphic showing that the system can do multiple nodes of data. They call them data nodes. And they classically can do nodes in different places. This we're just using in a private secure environment. We're going to be talking about this system in a lot more detail next week as part of the LISA webinar series. So tune in then for that one. I think the last slide here on this Translational Research Portal just sort of highlights the data sets in there, and then these sort of canned analyses. So these are pre-programmed analyses. You can see overview of data, summary of the positive patients, ICU outcome summary. These are the kinds of questions that most people are asking of the data set. So rather than have them download it and duplicate this over and over, we've canned those as clickable items. You don't get the row level data with these. You just get the summary statistic. And then there's also the opportunity to actually export the data, row level data, into your VRD. Again, it's de-identified, but it is row level data. And so with that combination, we can facilitate access to research data for investigators who are helping us battle this pandemic. This is just a graphic on the UC Data Warehouse one, which again, the UC Data Warehouse itself has 5 million patients worth since 2012, 100 million encounters, 300 million procedures, 1 billion measurements overall. So they've taken a subset of that as the CORDS data set. And today it has about 200,000. This graphic here shows last week. So you can see how quickly it changes and how many data points it really has. And again, that's almost untenable to export to your VRD regardless of the size, but we do, people can do that. So we anticipate providing this kind of sort of abstracted higher level analysis and platform for folks going forward with not just this data set, but other data sets that are disease specific. And I think that ends our webinar for today. I wanted to just acknowledge the UCSD Health Information Services folks. There's a ton of folks there that have worked on this. And I'm not going to go through all the names. You see your names up there: ACTRI, Biomedical Informatics, Research Compliance, which has been key in helping us make sure that this is compliant with regulation and policy. ITS as well in integrating with AD. Xpertech, Tag Bio, which has provided us access to their platform basically for free. While we're the first to use it for this kind of purpose. And then AWS, of course, and then my division of Biomedical Informatics, in particular, Paulina Paul, who's been instrumental in getting the data, and of course the Campus Lisa team, which I think has done a fantastic job with this webinar series, and we're very thankful for the opportunity to tell you about this project. So we'll stop there, and I think we'll entertain any questions. We want to provide plenty of time for Q&A, and I think we have about 19 minutes for that. So with that, we'll stop, and we'll start the Q&A part of the webinar.
Thank you, Doctor. We're going to invite our Q&A moderator, Rachel Hassett, to come on screen to coordinate this section of the webinar.
Thanks, Angie. That was a great session. Thanks for all the information. And it looks like there's some Q&As coming up, but I'm going to start with my own questions. So can you talk about how many hours of work went into designing and implementing this environment, and then how many FTE are dedicated to managing and granting access?
That's a great question. Total number of hours, I have no idea. Many hours. In terms of the time it took, the evolution of when we actually launched the environment was about 1.5 years. And part of that was just building it out, documenting it, validating that we had the right security controls in place, and we've brought in third-party auditors to kind of validate of what we put in place. And then, it's been another 2 years of actually living in and evolving the system as different research groups move into the environment. So total FTEs, really it is myself along with CTRI. So CTRI manages the activities in their account. I'm the one managing, along with Xpertech, everything that goes on kind of peripherally around the HIPAA environment, along with internal resources like networking. We work with obviously on a regular basis with the Palo Altos. So it's hard to put an exact hour on it because there's just so many kind of cooks in the kitchen. But there has been a tremendous amount of effort to get this all working, and there are people who aren't hands-on keyboard contributors to the process as well. Like we mentioned, many of the research groups talk to us about things that we are not experts in. So there's a little give and take in terms of knowledge. We build out the infrastructure to support them, and then work with them on figuring out kind of how to make that work, how to make their research work within the environment.
So can I maybe provide additional sort of add on there? I think collectively, if we were to go look at this as FTE, if I had to give it sort of man months worth of effort, as Andrew's mentioning, it's very difficult to figure out because people are doing obviously things that they normally do day to day, and then they're contributing some to this project. But right now, to manage the system as it is, Andrew doesn't do it full time. He also manages a lot of other stuff. And so I think collectively, if I were to really put a number on it, it would be somewhere around the order of 2 to 3 maximally, just collectively. But again, it's hard. The other thing that I would mention is we started this as a proof of concept. Why? Most of my colleagues out in the health research community, I started telling them what we were doing and why, and they just looked at me like I was crazy because they tried it and they got extremely negative pushback. And so we started this slow and easy. with one caveat that the only way we're going to furnish data to you, investigator, is through something like this. And so this is how you get the data. Then that was kind of the hook. But then we had to make sure we had a good service. And that's where we went from the sort of on-prem thing, which was a lot of hands-on, and it was, you know, a lot of licensing of VDI licenses and VMware, to the solution at AWS. We approached them when we saw WorkSpaces and said, hey, can we make a cloistered workspace? Which I think they were being asked to do by others, but had not really done, considered. So we worked with them and we created this sort of privatized workspace in this environment. And that really has led to much less need to have hours and hours on knob turning, to put it that way, on the environment, and because AWS is really running the WorkSpaces environment. So we have images, we create accounts, and we provision stuff, and it's a lot less of that engineering. Somebody asked about cost. At this point, the 2-cores, 4 gigabytes are $16 a month. And you're probably thinking, oh my gosh, imagine doing 20,000 of those for the campus. Well, we don't do that. We have 1,700 faculty. I'd say we believe that we probably need around 300 of these, because not every faculty needs this and they don't need it all the time. So this is sort of off and on, and when they need data and they're doing projects. So we anticipate about 300. Right now we have about 135. So overall cost with 300 or so at $16 a month is going to run around $100,000. And ultimately, at the end of the day, this is a cybersecurity maneuver as much as it is provisioning good high-level compute, reliable compute for them. So, adding as much honey as we can to counter some of the vinegar they need, where they have to double-click WorkSpaces instead of just going right into the data set on their laptop.
Great. That's not that bad. It's kind of reasonable for the PI. I mean, is the PI paying for this?
So that's a great question. In the beginning, we were required to pay. This wasn't viewed as a, as a cybersecurity core thing. And the price at that point actually was higher by AWS. I think the price has come down because a lot of people are doing this now, especially with COVID and distance. A lot of customers came to AWS, so the price per unit came down. It used to be $50 a month, and we were charging that, and it was really kind of an annoyance. So we've gotten the health system and CTRI co-invest in this, and so the 2-core 4 gig, which is plenty for most people, is provided for free. It's complimentary. They do, when they do a data extractions, they do have to pay for those because that takes an analyst to do those. We're about to automate a lot of those low-level ones, so they don't have to pay for that. But the VRD is complimentary, and then the larger ones they do have to pay for. We're right now doing a proof of concept where we underwrite that, but those will probably be about $100, a month, and those are for much higher level users. The postdoc who knows Python and has a machine learning thing they want to do, that they want to do on the VRD instead of doing it in an EC2 instance, which is probably more appropriate, or in a cluster. So the cool thing about this is it's a gateway to all of the HIPAA eligible services. And so just to give you an idea, I've done research in NLP for years in medicine, and there really isn't a scalable service, NLP service as a service, but now AWS has Comprehend Medical. So we now, just by the fact that we're in the AWS environment, now have a clinical NLP engine that can be provided to researchers who want to use that. So that's one of the advantages and one of the big advantages of actually moving to a commercial cloud. And I'm saying AWS, but Azure has, other, additional stuff. So they all have sort of their secret sauce, and then 80% is in common. So we anticipate doing this with other environments as well. We started with AWS, and I don't think we'll do VRDs anywhere else, but we'll probably allow for connecting of them to like GPC and maybe Azure for things that they have that Amazon doesn't, or where the pricing is more competitive. So we try to be as cloud agnostic as possible.
And the other thing I did want to point out from an account standpoint, like if somebody comes in as requesting an AWS account outside of the VRD, UC San Diego Health is actually subsidizing the security and infrastructure and the networking costs for those accounts. You're still paying for the compute within your environment, but we're paying for the Palo Alto, we're paying for that Bastion host. Anything that we're requiring from a security standpoint to protect that HIPAA boundary, we're covering, but you're paying just for what you're doing in that environment. So I think that's been actually a great partnership from an institutional support standpoint to provide, the environment where people can go and do their research.
That kind of brings us to the next question. This is from Michael Oliva. He says, this all looks amazing and expensive. Are you using a VPN or direct connect to go from on-prem to AWS? And is there any lag or slowness?
So we haven't experienced, we are using IPsec tunnels. We're not using direct connect currently. We haven't had any bandwidth issues. We actually did a significant amount of testing in the Wayback Machine when we first built this, because I didn't believe that some of those tunnels would sustain some of the data we could throw at them. But surprisingly, we have been only able to saturate the tunnels a couple of times, and that was just through blasting massive amounts of data. But that being said, we are evaluating direct connect and other options for more bandwidth, but the scenic backbone has been good to us, and we have, there was a diagram that we didn't show on there just because it's a, kind of looks like a spider web of craziness network. People would love it, but each VPC has its own IPsec tunnel that runs through those Palo Alto firewalls. So that being said, it's dedicated IPsec tunnels for each one of these VPCs. And expensive, it's all relative, right? If you're going to build a large compute infrastructure on-prem, you're going to pay for that infrastructure. That you got to consider the power and the building itself and the security around it. There's trade-offs in moving to the cloud, but one of the things that if you're trying to just lift and shift things into the cloud, they're not going to run as effectively as if you're going like serverless and leveraging Lambda and function type services or other infrastructure. And there's other ways to kind of manage that infrastructure to keep your costs down, like leveraging the spot market and stuff like that.
So if I may just kind of chime in with respect to costs, from a total cost of ownership perspective, as my colleagues have mentioned, we've done some analysis and comparison of doing on-prem as licensing and solutions. And then when we actually compare it against AWS, just the key here is just really the fact that we can do things as shut things down when they're not needed, and really only turn things on when they're needed, and architect things in a way that they're really cloud native. And as Andrew mentioned, they're not just lifting and shifting VMs into the cloud. That's where we've gained a lot of savings. And, additionally, it's just been able to really shift a lot of our staffing resources to the consultation side and not having to worry too much about the infrastructure management of it, and because AWS handles that. That's given us a lot of value in terms of how we deeply connect with our researchers, and that's given us a lot of great feedback as well.
I see another question there about how many researchers or research groups. When I think last count we talked about, we do a stand-up every week. I think it was 130 some odd, maybe more now, VRD users and research groups. How many would you say, grouped together, including my VOLI group, which has 3, I think.
Yeah, we're about like 140 or so at this point.
Yeah, and I would say probably somewhere like 6 or 7 research groups, but then most of them are independent people. We get a lot of requests by individuals. So they're not really a research group, they're an individual, and they're doing it for their research, and they get IRB approval and they do the extraction. Today we only put the extracted data into a VRD, and that was a big sort of social, technical, political, thing that was I think hard to kind of not hard to do from our perspective, but my colleagues across the country were pretty amazed that we were able to pull that off, and I think part of it is just because we were able to afford people a little bit better service in some areas, and it was fairly convenient. But there is downside. There are people that insist on having their data because they have to do special compute on it in some respect, and we do try to work with those folks. And the externalizing of that data can't be done by them. It's done by our staff, and it's done very carefully. And we actually vet the data to make sure it's what they say it is and that kind of thing. In terms of making this broadly available, this is for the health system or health professions folks. So, but I did notice recently, if anybody from the Sherlock team at SDSC is on, I did notice that Sherlock is offering something called Skylab, which I think is very similar in nature, you know. So I would encourage people to really think about doing something like this, even for non-PHI, because of what happened at UCSF. And so you really need to protect your data, you know, your data assets, because you really don't want to be talking to your NSF grant, you know, officer about how your data was ransomed and, you know, you got to pay 50,000 or 5,000 or whatever to get it back. That's not a good position to be in, regardless of whether it's, you know, HIPAA or not. So I tell people you need to secure it anyway. So we tell people this is for HIPAA PHI, but we encourage people to put anything of value in here rather than walking around with it on a laptop.
So I want to see Steve's question around the BAA. So remember that HIPAA compliance also involves you know, having your security officials signing off on something. So in health, yes, there's a BAA in place. You have to be under the AWS Enterprise Agreement, but for that BAA and HIPAA compliance, we have to be able to provide visibility to our Chief Information Security Officer, Ken Watkey, on the health side. On the campus side, that's a discussion you know, you need to have with like Mike Korn's group in security in terms of the effectiveness of that BAA and really being HIPAA compliant.
I would underscore, by the way, that there's one BAA by UC. There's not campus level BAAs. And that one BAA you can actually download from UCOP. It is a PDF that's been signed by UCOP Council. And they re-up it every few years. I think the latest one, it was signed, I think in 2017. So you should be able to download that and we can furnish it. So whenever I deal with companies, and the first thing I do is I give them that and say, look, it's a non-modifiable BAA. There's no redlining here. Either you take it or you don't. And that's the bottom line. So that one's really simple. What isn't as simple is just because you have HIPAA eligible services somewhere and somebody signed the BAA doesn't mean that you should put PHI on it, because the CISO, HIPAA says that the CISO, the Security Privacy Officer, dictates what controls you need. And that's the beauty of that law. It did not dictate the controls, because we'd be stuck with 1996 controls. It said you have to do an annual review, which we do, and then the officer, you know, security officer dictates what you should do locally. And in addition, they really need to have transparent access to what you're doing, which is what we do. So this is why we normally in the health system would not put our PHI in Skylab, because, you know, we don't have transparent access there. I mentioned Skylab for those of you on the campus who need to have more of a protected environment. But the health system has the one that we have ongoing monitoring by the security team here on, and that's where our PHI goes, and only there.
Looks like that's all the Q&A that we have. So I'm going to hand it to Angie. And well, first, I don't know if there's any closing remarks before we hand it to Angie, but we are about done.
There was one more question, I think. I don't know if there's time to answer that one.
Yeah, it just came in. Yeah, it says, awesome work on the VRD and establishing HIPAA compliance on a virtual system. Have you thought about extending this to outside UCSD for researchers? Tag.bio has some methods to share cohort-based anonymized data sets. Differential privacy could be another way.
Yeah, that's a great question. We're not looking at that right now with the TagBio system. We are using TagBio in a very different use case that they're used to, which is inside of this closed environment. And but they obviously have the capability to do nodes, and we haven't gone there because we really haven't needed that at this point. In terms of researchers from elsewhere, we have discussed extending this out to other sister campuses that don't have this kind of infrastructure, that are health system campuses, and specific UC Riverside, for example. which has a very small health practice, and we host their EHR already. And so it would be a natural thing. If they want to extract data, we could do it and put it in a VRD for them. And what we would normally do is have that as a segregated area for them. As Jit and others showed, within our environment, we have these siloed VPCs that don't have inter-VPC communication. And so DBMI, for example, has its own, CTRI has its own, HSIS has its own, and then UC Riverside would have its own, or UC Riverside Health would have its own. So that's kind of what we're looking at doing. And they would basically get AD access using a TAF, a temporary affiliate form, which we would sponsor. They get AD, we'd set them up, and that's how we do it. We're not thinking of broadly making this available broadly because of the cost, obviously, but we're happy to tell people how we did it, and people can copy what we've done. There's no private IP here from our standpoint. This is all shareable.
Thank you, Dr. Hogarth. This concludes our presentation. I actually want to thank everybody who was able to attend today, including our presenters for sharing their time and insights, our captionist, Susan Thomas from eCaptions, and our moderator for the Q&A section, Rachel. And of course, you, the audience, for attending. Please refer to campuslisa.ucsc.edu for more information. And I hope to see everyone at our 4th Campus Lisa webinar next week. Have a good day.